So one of the first questions that the patient, when she comes to see you in your clinic with the family, ask you is how is the risk for my daughter? How is the risk for my my sister to have cancer like I have? And it's a little drama. The patient feels herself responsible of the fate of the family, of the daughters, even if the daughter is 10. They are very, very worried. And the reason why this is the first thing that they ask, can I have the test done? And in the United States, it's very common to see patients with atypical dysplasia, patient with papillomas, patient with fibrocystic dense breast to be tested by the family doctor, by the breast surgeons in the community hospitals. So it's frequent. This test is becoming more and more frequent and sometimes, of course, inappropriate. But when we need to test a patient for the BRCA gene, a patient with breast cancer, of course, my lecture is focused on patients with breast cancer. And this is the draft of the last draft of the final NCCN guidelines on the recommendation for testing. This is a courtesy by Dr. Robson. This is our genetist that is strongly involved in this recommendation, in this organization, brand new. And of course, you need to test a patient when you know mutations in the family, but again, when the patient is young. But the definition of young changed over the time, because before was 35 years old, then 40 years old, and now is 45 years old. So you need to test the patient that has cancer when she is less than 45. And of course, the situations in which there is a family member, but you can see that when there is just one close with breast cancer less than 50, so not such a strong family history, ovarian cancer, relative with ovarian cancer, or even two close blood relatives with pancreatic cancer. Of course, if the population is at risk, but the important introduction in the recommendations are the submolecular, the molecular type of cancer, the triple negative. So you need to test now in the United States patients less than 60 with triple negative cancer. And the reason is clear, is of course from many experiences. This is an unpublished study, courtesy of Bernardo Bonanni, friend at the European Institute in Milan, and they test, they saw BRCA mutations in patients without family history for breast cancer, triple negative, when they are 45, in 25%, quite high. Without family history. Of course, the other type, luminal A, luminal B, less frequent, probably the basal luminal A, positive without family history, or of course with family history, the risk, triple negative, is much higher. But even when the patient is 50, you can have 65 risk of having a mutation with family history, and you can see that is quite independent on the age of the patient. Other very interesting experience from the Australian database on patient triple negative, and even when they are more than 60, you can have 15% risk of mutation. Without family history, we don't know. Perhaps that is a bias because the patient is old and may not recall any family history. But anyway, the risk, you can see, is quite high. So sooner or later, we would test all the patients with triple negative cancers independently on the age. Well, many institutions are still working with the BRCA risk calculator. This is a nanogram on the website in which you put some data of the patient, but of course is obsolete, especially on this new recommendation. It doesn't take into consideration the, again, possible biology of the cancer. And this type of nanogram is very focused on the type of patient, the ethnicity of the patient, of course, Ashkenazi Jewish population. And you can see that if a patient with breast cancer less than 50 is not Ashkenazi, the risk is 4.7. Many institutions in Europe, but even in the United States, put the limit at 5, so this patient wouldn't be tested for the BRCA gene. But if the patient is Ashkenazi, it's 2 times, and she would be tested. And it is true even without cancer. So patient without any breast cancer, without any family history, 1.5 risk, that is the general population risk, but 8 times more if the patient is Ashkenazi Jewish. The main problem, especially in Europe, I don't know here in Brazil, is that the Ashkenazi Jewish migration was in 14th centuries, and many migrates from Northern Europe in of course Southern Europe, Pope territory, and no one wanted to be Jewish in this area. So many of these populations, person lost the tract, and they don't know if they are Ashkenazi, but they are Ashkenazi. And it's very interesting to see mutations typical of the Ashkenazi mutation in New York. American Italians, very Catholic, they don't know anything about the Ashkenazi, but they have the Ashkenazi mutation. So we cannot have the BRCA pro, especially in Europe. In the States, probably the Ashkenazi population is more close and well, and they know very well about this. But returning to the recommendations of for the gene, you can see that the recommendation is also focused on other type of cancers, sarcoma, pancreatic cancer, kidney cancer, of course invasive ovarian, male, all the male breast cancer should receive the test, but it's focused also on other cancers. Why? To catch the possible other mutations that may be present, and like the HEP mutation, Li-Fraumeni. Why? Because with the somatic mutation that we are seeing more and more when we test the tissue, when we test the cancer, we may discover also some correspondent genetic mutation, and of course we may lost this information if we don't test at the beginning the patient. And this is also the reason why there are these multi-panel, now in the States, multi-panel genes array to test for more than one mutation, BRCA1, BRCA2, PALM mutation, Li-Fraumeni mutation, P53. Why? Because often you have some syndrome overlap. So patient may meet the criteria for having different tests, and you can really discover different syndromes in these patients dependently on the relative that they have and dependently on the cancer. But why is important for a cancer patient to know that she has the mutation? It's very important when you plan your surgery, because we know the possible increased risk of local recurrences when you do conservation therapy. And we also know the risk of contralateral breast cancer. This is one of the first studies, our study by Robson, showing almost 2 times the risk of local recurrences. And more you go with your follow-up, and more is your risk of local failure when you do conservation surgery. But interesting to know is that the failure, the local failures in these patients is a late event. So what does it mean? It's not a true local relapse, because the local relapse are almost the same in this paper, for instance, comparing carriers without carriers and patients without mutation. You can see that it's a late phenomena stressing the fact that the failure is a second cancer, and often is a second cancer the same as the first, often triple negative, often difficult to treat, and often, of course, impacting the survival of the patient. Second cancers may also due to the radiation therapy. This is an elegant study just published by our group reproducing in vitro the damage of the cells during the radiation therapy with 3 lines of cells, normal, or with the BRCA1 and BRCA2. And this is the recuperation of the DNA after the radiation therapy damage. And you can see that the cells with the BRCA1 and BRCA2 don't recuperate. So we may say that the radiation may contribute to a possible second cancer. It's a speculation, of course, but this may be the experimental evidence. But what about the contralateral breast cancer? Of course, contralateral breast cancer in patients with mutation is higher, but can also impact the survival. One of the major contributor of the data on BRCA patients after breast cancer is the Canadian group with this excellent, strong database, and they were able to show the difference, but this difference can impact the survival. And from the quantification point of view, BRCA patients without the contralateral prophylactic mastectomy, they may have about 50% more mortality in 20 years. Again, the second cancer, contralateral cancer, may be bad, may be triple negative, may require chemo, may kill the patients that survive from the first cancer. And what about the oophorectomy? The oophorectomy is also very protective. This is a paper showing the benefit of oophorectomy in patients with or without previous breast cancer. And you can see a high level of protections in both patients. But this group compare patients with unilateral mastectomy, bilateral mastectomy, oophorectomy, and you can see that the oophorectomy plays a very, very important role in this preventive management as the bilateral mastectomy. So both combined can give you a very level of protection independently on the primary cancer, independently if the lymph nodes were positive, on the chemotherapy. It works. It works very well in any case. And in a multivariate analysis, univariate and multivariate, you can see the difference dependently on the age. Of course, the oophorectomy is better in younger age. Why? Because the life expectancy is long, so the level of benefit is higher. Stage 1, but even stage 2 breast cancers, and also in negative hormonal status cancers, stressing the fact that the prophylactic oophorectomy is not only beneficial as for the first cancer, for the first positive cancer, but also beneficial in ER negative in terms of protection against the ovarian cancer for these patients. Well, of course, we try to answer our patients regarding the test, if they need the test, but when they need the test, what we need to do? It takes about 4 or 5 weeks to have the test, so we will need to decide. The New York patients, but I think in all the world now, the patients will like the treatment the day before, so they are extremely worried, and you cannot tell the patients, well, you need to wait 5 weeks and then we can do the surgery. So what we do, if the patient is candidate, we do the lumpectomy, we may do the oncoplastic surgery, and then we wait the final pathology, and if the patient may need chemotherapy, or in the meantime, before starting the radiation therapy, we have the result of the test, and if the test is positive, of course, the patient will go for the prophylactic mastectomy at this point, because the cancer is out. And especially if we do niposparin mastectomy, having done the mastopesis before can help us in having better results for our niposparin mastectomy. And of course, you need to plan oophorectomy dependently on the age of the patient, and this is a very difficult question. Niposparin mastectomy can be done in BRCA patients. This is our paper impressed on the British Journal of Surgery, in which we perform 177 niposparin mastectomies for cancer of prophylactic, and we didn't have any cancer back. The follow-up is not long, but quite, I would say, reassuring. 0.45 to 6 years follow-up. So we are confident in doing niposparin mastectomy in these patients. So I would like to finish with I would say, some recommendations, some observation. No doubts, lumpectomy in these patients can increase the risk of secondary cancer. Contralateral mastectomy improves survival. Prophylactic oophorectomy improves survival. And of course, you need to deal with the situation of the patient. If the patient has stage 3 breast cancer, if the patient has a very poor prognosis, the common sense is, of course, to wait and then to see how the patient will go and think later on about the prophylactic measure. Thank you.